Well, good evening, everyone, and welcome to tonight's Goodfellow webinar on the investigation and management of male and female subfertility in primary care. My name is Dr. Hazel Fuyava. I'm a GP in South Auckland and I work for the Goodfellow unit. Tonight we have Professor Cindy Farquhar, Dr. Elizabeth Glanville and Jeanette McKenzie with us. So for introduction, Cindy is a professor of obstetrics and gynecology at the University of Auckland. She trained in medicine at the University of Auckland. Her specialist training was in Auckland and London, where she completed her MD in research. She has over 300 peer-reviewed publications, and she was the co-chair of the Cochrane Governing Board from 2014 to 2018. In 2014, Cindy was made a companion, of the New Zealand Order of Merit, and in 2019, she was made a Fellow of the Royal Society of New Zealand. In 2023, Cindy was awarded the Gluckman Medal, and she is the Clinical Director of Fertility Plus at National Women's. Elizabeth obtained her medical degree from the University of Bristol in the UK and has trained in obstetrics and gynecology in UK and in New Zealand. She completed further training as a subspecialist in reproductive endocrinology and infertility, and she works as a fertility specialist at Fertility Plus, Te Toka-Tū-Mai and ReproMed in Auckland. Elizabeth is also an honorary lecturer at the University of Auckland. And Jeanette is a graduate of the University of Otago in Dunedin, where she completed her research project looking at the effect of plant estrogens on male fertility. Jeanette then completed a Masters in Clinical Embryology at Monash University in Melbourne, Australia. Jeanette has been working in the human IVF field for over 19 years. Jeanette started her career as an embryologist within a private clinic in New Zealand and worked across all aspects of the clinical laboratory prior to moving to the UK. She then spent 10 years in the UK working as a lab manager and quality lead for the London Women's Clinic. And I will now hand over to the team. Thank you.
Thank you very much, Hazel, for the introduction. This is an outline of what we hope to cover. So a bit of a background and introduction, quite a bit on evaluation of couples with infertility, some on initial management in primary care, and when and how to refer. We're going to cover a little bit of our management in secondary care. We will explain how the public funding works, so what the criteria are both for referral and for publicly funded fertility treatments. We're going to illustrate some of our information with some cases, and we're also going to cover third-party reproduction and pre-implantation genetic testing. I'd just like to mention our website here. So Fertility Plus is our clinic in Auckland. There's 3 fertility clinics in Auckland. We are the public clinic, but all of the clinics do have some of the public contract for fertility treatment and consultations. So there's lots of information on our website if you find the talk too boring and wish to go and peruse that as we go, or otherwise maybe just later on. So a bit of background, what is infertility? So the World Health Organization defines infertility as a disease of the male or female reproductive system, defined by the failure to achieve pregnancy after 12 months or more of regular unprotected intercourse. But the ASRM have recently proposed, so that's the American Society, to broaden that to also include people who need medical intervention to conceive. So that might be same-sex couples who are looking for donor gametes, or single individuals, and this is just in the hope to not exclude people who don't have that sort of traditional definition of infertility. 1 in 4 people in their lifetime in New Zealand will suffer with infertility, and it's not just couples, as I've said. Female age is the most important factor when it comes to spontaneous or natural conception or assisted reproductive treatments. 85% in general of couples will conceive within 12 months of trying, but of course that's going to be dependent, as I've said, on the female age. So this just gives us some better idea of, if you were younger, age 19 to 26, what your chances of pregnancy after 1 or 2 years. So 92% after 1 year, 98% of couples after 2 years in that age group. And by the time you're getting to the age of 35 to 39, that's going to be 10% lower, 82% after 1 year and 90% after 2 years. And I think one of the important takeaways from this slide is that you shouldn't be dismissing those young couples who are coming to you with 2 years of infertility and saying, oh, well, you're young, you'll get pregnant eventually. Well, actually, they're much more likely to have a pathology if they've been trying for 2 years and they're still not pregnant, because they had a 98% chance of being pregnant in the first place. So we probably all know what the causes are of infertility, but it's sort of generally distributed between disorders of ovulation at about 25 to 35%, disorders of the fallopian tube and or endometriosis around 25 to 30% as well. Male factor 25 to 30%, and then a combination of both male and female 15%. More than one cause being present, whether that's in the female or male or both, 30 to 40%, and unexplained is 20 to 30% of couples. So I think this is probably mainly what you came here for. So I'll try and detail as much as possible about what we expect in the evaluation of your infertile couple, with the knowledge that in primary care you do have a limited duration of time during your consultations. But if you can get as much information as possible, it's really useful with your referral to us, so that then we in turn can give that couple as much as we can from their half-hour first specialist appointment in the public system. So if you can find out how long have they been trying to conceive for, and that's not just that sort of active trying, but how long have they not been using contraception? Because many couples say, oh, we've been trying for 6 months, but actually they have never used any contraception in the time they've been together. So if they have used contraception, what was that? It's really useful for us to know if they've been on the pill, so that we can be guided by the duration of time that they have been exposed to the chance of pregnancy. That also factors in, as we'll discuss later, to their chances of getting publicly funded treatment. So it's actually really important we have that information accurate. How often are they having intercourse, and when during the menstrual cycle? Do they have an understanding that they're not going to conceive if they have intercourse during the woman's period, for example? And are they having intercourse, more than once in the fertile phase? It's really important that they're covering that whole duration. We recommend trying to have intercourse every other day during that fertile time. What are their menstrual cycles like? Are they regular, suggesting ovulation is occurring, or irregular, suggesting things like polycystic ovary syndrome, for example? And when their period does arrive, is it very painful, suggesting things like endometriosis, or heavy, which might point to something like fibroids? What are their previous pregnancies? Do they have children? This is really important for the public funding again. They wouldn't be eligible for an appointment to be seen if they already have 2 children, as Jeanette will cover more on later. If they've had pregnancies, have they had recurrent miscarriages or an ectopic? And their gynae history. So do they have risk factors for tubal disease, for example? Have they had chlamydia in the past? Is their cervical screening test up to date? If it isn't, it's a good opportunity to get that done. And with self-testing now, that's, I imagine, much easier in primary care too. Their medical and surgical history can be really important, because if they have any sort of medical issues that might either impair their chances of getting pregnant or impact on their health during pregnancy, or if they're taking any medications for high blood pressure, for example, you want to make sure they're safe during pregnancy. Their social history is also very important. Smoking will preclude them from being eligible for public funding. Obviously, most people know we shouldn't be drinking alcohol, but you just got to make sure that you've stated the obvious to your couples or individuals as well. And vaping is also included in smoking as well. Family history would be relevant, especially if there's any sort of pregnancy-associated family history. And the partner may not be your patient. If they're not, then they do need to go and see their GP as well, because as you just saw, the male is just as implicated. So are there any issues with intercourse, any issues with erection or ejaculation? Has the male had previous paternities in other relationships? That would be a prognostic indicator if they have. And does the man have any medical or surgical history, including testicular problems like surgeries or a mumps infection in the past, or any sexually transmitted infections? Examination, we recognize that you don't have a long time seeing your patient, and actually a lot of the time it's not necessary to do a full examination and a vaginal examination, but you might want to do a targeted assessment, particularly if you are concerned that the woman might have fibroids, for example. It'd be useful to do at least an abdominal palpation. In general, you just want to know blood pressure, height and weight, and their BMI is important for the referral. If they have irregular cycles, do they have any other stigmata of PCOS, for example, hirsutism or elevated BMI or skin changes? And the other sort of underlying causes of irregular cycles would be things like a prolactinoma. So you might want to evaluate their visual fields and check if they have any galactorrhea and signs of thyroid disease as well in that situation. Your basic investigations will include an FSH and estradiol. We like this done during the early follicular phase, so day 2 to 3 of the cycle. This is where the estrogen should be at its lowest. So the FSH should be at the point where it's going to indicate their ovarian reserve. If you take it later in the follicular phase, the estrogen starts to rise and suppresses the FSH, so we're not getting an accurate idea of their ovarian reserve. So they take it during the 2nd or 3rd day of their period. Antenatal blood screening, so that's going to include all your serology screen, hepatitis, HIV, and also checking rubella immunity is important, plus HbA1c. The luteal phase progesterone, so that's usually if someone has a 28-day cycle, it would be day 21, but you need to change that according to the duration of their cycle. So if they're having a 35-day cycle, then you'll want to do it 7 days before that. And if they've got a really irregular cycle, you could suggest that they have serial progesterones, day 21, day 28, day 35. Cervical screening test, as I mentioned before, plus or minus swabs for infection, because if they're going to undergo fertility treatment, we do like to make sure they don't have any infectious risk. Pelvic ultrasound, if you think they're going to need it and you can request it from primary care, we'll speed it up for them to have the investigations completed. But if they haven't had one by the time they see us, we do usually arrange one. And if they do have amenorrhea, then checking that prolactin level, testosterone and TSH. But it's not necessary to do a prolactin level routinely for everybody. I mentioned here genetic or reproductive carrier screening because this is something that more and more people are now interested in. There is a pamphlet I've just taken a shot from there, from RANSCOG. You can get that online. You can point your patient in the direction of the RANSCOG website. We can print them off. It's really worth familiarizing yourself with this test. The patient would have to pay for it. In Australia, it's now funded. It's recognized that it's really important to know if you're a carrier of cystic fibrosis or SMA. But in New Zealand, obviously, we're not funded for this yet. It is quite expensive, but I'm finding more and more couples are taking up the option of this. And the AMH level, so that's a really big question. Again, not funded, costs around $85. You probably get a lot of patients coming in requesting this test. I think it's important to understand what it means. It doesn't tell us about the chances of the person becoming pregnant naturally or even through assisted reproductive treatments. What is useful about the AMH is if the couple will end up needing IVF, it's useful to know their AMH, the female patient's AMH level, because it predicts their chances of responding well to the drugs that we use in IVF. So really that's its only use. It's not going to tell us about her chance of conceiving, her chance of having a healthy pregnancy. It is usually elevated in polycystic ovary syndrome, although it's not exactly a diagnostic criteria. And it does, as you can see from this graph, reduce with age. Don't forget the male, so he will also need his serology screening. And then really there's only one main test for men, and that's the semen analysis. Jeanette's going to give us a lot more detail on that. If you ask the man to have his semen analysis done, it's abnormal, get him to repeat that because if it's mildly abnormal, on repeat, it may well be normal and reassuring. Try to aim to do that a couple of months later, not just immediately afterwards, because it would be affected by something like a viral infection, and you want the chance for that spermatogenesis to recover from something like that. But also check that he's not taking any medications that might impact on his sperm quality. Talk to him about lifestyle advice, such as making sure he's not smoking or causing overheating of the testes through laptops on the lap, spa pools, cycling, things like that. Antioxidants are an option. These are not funded. They're things like Menavit and vitamins that you can buy at the pharmacy. they're actually not proven in research trials to improve the chances of pregnancy, but they certainly wouldn't do any harm if the man is happy and wishing to take them.
So the World Health Organization published guidelines on the examination of semen, and the last publication was in 2021. And the figures that they come up with in the guidelines are taken from a lot of data, over 3,500 men who have had a time to pregnancy of 1 year or less. And that was over 12 countries in 5 different continents. So the guidelines recommend that the best method of producing a sample is by masturbation into a sterile pot. The man should keep the sample at an ambient temperature. There's no need to put it in a chili bin and keep it cold, and there's no need to artificially heat it. So just keeping it in their pocket is absolutely fine. And before they do the sample for analysis, we recommend 2 to 3 days of abstinence before. Now, the assessment of the semen should be done within 30 to 60 minutes after the sample was collected. So in the community, it may be quite tricky to get to the lab in that time, but it's on the reports how long it was till the assessment, so you can keep an eye on that and make sure it was done within 60 minutes. In the community labs, they'll do a basic analysis, and what they're looking for is a volume over 1.4 mils. They want to see progressive motility of above 30% or a total motility of over 42%. A sperm concentration of over 16 million per mil, and a total sperm number of over 39 million per mil. Now, we do get our patients to do a community semen assessment, and if there's abnormalities, we'll get them repeated in our own laboratory and do a tertiary analysis. We'll repeat the volume and motility and concentration, but we'll also add in anti-sperm antibodies, which need to be less than 50% to pass the test. And we also look at non-sperm cell counts, and that should be less than 1 million per mil. If we see quite a raised number of over 4 million per mil, we'll send it off for further testing in the lab for culture and sensitivity and infection. And also, if we see no sperm at all, so azoospermia, we will send it off for fructose testing.
So just a nice summary for you of the 4 key points you need to ascertain from your history and further evaluation is the woman ovulating? Is she likely to have patent fallopian tubes? Does the man have enough sperm? And are they having sex often enough for the egg and sperm to meet? What you can do in primary care is make sure your woman's taking folic acid and iodine. If she is overweight, or if the partner's overweight, you can give them advice about weight loss. And we know that BMI is definitely going to have an effect on natural fertility. So this is important, but it also does come into the public funding criteria for treatments and referrals. If they're smoking or vaping, they do need to quit. Otherwise, their first specialist appointment is unfortunately wasted. If they're drinking alcohol, obviously they need to quit. Any illicit drugs, making sure that if they're exposed to toxins through workplace exposure, for example, just discussing that, ensuring that they're following just a healthy, balanced diet. There's not really a known specific fertility related improving diet. And exercise is great. Women worry that they can exercise too much, but certainly if they're exercising before trying to conceive, they can continue exercising when they're trying and when they're going through fertility treatments. Stress, look, it obviously would be better not to be stressed, but as long as someone's still ovulating, if they're stressed, it probably isn't having a major impact on their chances of becoming pregnant. And as we've talked about already, the timing and frequency of intercourse. So when should you ideally refer? So this is not necessarily the public criteria, which we'll come to later. You should be referring any couple trying for 12 months or more. But if they're over the age of 35 and they've been trying 6 months, then that's probably best to refer on at that point. If they've got a known severe factor like for example, they've got no sperm, or they're known to have blocked fallopian tubes, severe endometriosis, you can definitely refer them earlier than that. Other reasons, as I mentioned earlier, it's single-sex couples or single person or same-sex couples, or if anyone is a known carrier of a genetic condition and at risk of having an offspring with that condition. So the public funding criteria will come to, but the patients can be referred privately, and they can refer themselves. They can just call the clinic and make an appointment. It's ideal if they've had some of the investigations we've discussed to get the most from that appointment. But all the clinics in Auckland will accept self-referrals and offer self-funded treatments, including us at Fertility Plus.
So I'm going to talk to you about the chances of people becoming pregnant without treatment. And there is a prediction model that you can use. It comes from the Netherlands. And here it is here, doing that. So this is the probability of spontaneous ongoing pregnancy leading to a live birth within 1 year. And it's not to be used if you know that they've got a problem. So ovulation disorders, male factor, pathology of the tube. There's a funny question there about post-coital tests, so you can just ignore that. And then you put in the age, duration in years of trying, previous pregnancies, yes or no. For some reason, being referred by your GP or by a specialist was part of the prediction. So referred by a GP in this case. What were the percentage progressively motile sperm from the sperm count you've got? 60% in this case. No tubal pathology and at HSG or on laparoscopy. And then you press the calculation button, and you'll see that this person who's in their 20s has a 43% chance, so almost 1 in 2 chance of conceiving, and that they may come to the clinic. We might see them just on that 1 year, but we would generally encourage people to keep trying when you've got a prediction model such as that. I mean, you might check out a few other things, but at this point, I would consider that they should keep trying. Here's the difference if you're 37 years old. After 1 year, same factors, and it reduces it by about, by 10% or so there. So, this model comes from the Netherlands, and I know in the Netherlands at this point they would start to be able to treat. Unfortunately, the way our funding works, this will not get you treatment yet, but we'll come to that later. And the next slide is someone who's been trying for 3 years, and you can see there how that decreases it even more. So somebody might wonder, why are we only looking at the progressive motile sperm? Because that's actually the main predictor from semen analyses. That's the most important factor for becoming pregnant. So the volume is, one thing, the concentration's another, but whether or not they're motile is quite critical. Right, so to turn to fertility treatments, it does depend on the cause. And I'd just like to sort of say it's not all about IVF. So if you're just breaking it down, what are the common categories or reasons for not conceiving? Tubal blockage, obviously, that's going to be IVF because we need to bypass the fallopian tubes. And I mean, that was where IVF really came from, is that we, by the way, it's going to be 40 years celebrating IVF in New Zealand, this just coming up in the next couple of months. But I was a junior doctor at the time, and it was very exciting to be working at National Women's when that first baby was born. And I do remember much older and wiser people sort of saying what a breakthrough it was, because prior to this, if you had if you had blocked tubes, you had nowhere else you could go. The next cause there of poor semen, we could swap out the semen, obviously use donor sperm, but blocked tubes, there was nowhere else to go. And so you can see we've put the live birth rates per cycle, aged for between the ages of 30 and 35 there. So, you know, IVF, very successful treatment, no doubt about it. If the sperm are the problem, then we can do IVF with ICSI, where the sperm are directly injected into the oocyte on the day of the egg collection. And that actually has slightly better chances there because you're overcoming quite a major semen defect there with the direct injection. And then there are the ovulatory disorders, and we do quite a lot of ovulation induction, and we'll talk about that shortly. And the chances over the 3 to 6 cycles ranging between 30 and 50%. Unexplained infertility, well, the recommended treatment really should be to start perhaps with intrauterine inseminations. And there are the success rates over 3 cycles there. That's a combination of ovulation induction with either clomiphene and letrozole and the direct injection of or insertion of sperm into the uterine cavity. And then I'd say second-line treatment for unexplained is IVF, and of course that has higher chances with a single cycle, but and with repeated embryo transfers. The hysterosalpingogram is a test that mostly will have to be arranged by the fertility clinic. And I consider this to be both a diagnostic test and a treatment. And the reason is that quite a big clinical trial actually has shown, or many clinical trials have shown that using either Omnipaque or Lipiodol, that there seems to be an improvement in pregnancy rates after doing the test. But a large study published in 2017 comparing those two suggests that Lipiodol should be the first-line treatment if you have no risk factors for tubal disease. And this study showed a 10% higher chance of becoming pregnant. So here is the graph. We've got months along the bottom and the ongoing cumulative pregnancy rate going up the vertical axis, and you'll see that the oil-based medium was associated with improvements over the water-based medium. And by 7 months, 40% of patients were pregnant in the study. And I mean, that's pretty much similar to an IVF cycle. So we're pretty keen on Lipiodol in our clinic. And we do, when we order hysterosalpingograms, if they have a normal scan and no risk factors for tubal disease, we will request the Lipiodol. And this can also be done in through private radiology groups, although it is quite an expensive test, around $1,000.
So I've got 2 slides to outline. This one first is the criteria for the referral for a fertility appointment, and the second slide is eligibility for the treatment. So there's 2 separate processes. So for our referrals from you, the woman needs to be 39 years old or younger at the time of referral, and the male partner needs to be 54 or younger. At the time of referral, the woman's BMI needs to be less than 35 and the man needs to be less than 40. They need to be New Zealand residents or have a work permit for 2 years, and that's both man and woman. They need to have been trying for 1 year to get pregnant or have a known severe cause. So if they've got anovulation, azoospermia, blocked tubes, or a genetic condition that needs pre-implantation genetic testing, those known severe causes, you can refer them straight away. But if there's no known reason as yet, then 1 year of trying. Just to point out that these are the criteria for the northern region in New Zealand. We're aware that in some regions there may be slight differences in the referral expectations, and one of them is in the Wellington region, that women less than 35 years old need to be trying for 18 months. So people are not eligible for a referral if they've been smoking within the last 3 months, if there's documented illegal drug use within the year, if there's alcohol abuse within the year, or if they're in a correctional facility. You can't refer them. If there's 2 or more children living in their house, and that includes adopted children, then they are not eligible. And if the children are from a previous relationship and they're living at home at least half of the time, then having those 2 children precludes them from referral as well. When you send the referral through, you need to include their day 2 FSH and estrogen levels, which need to be done within that 12 months. The man needs to have a semen assessment. And then in the northern region, all the referrals get sent to NRFS, and then they allocate to one of the 3 clinics in Auckland for CPAC scoring, and the rest of New Zealand, they go to Fertility Associates. So this slide here is how we do the CPAC scoring to see if people are eligible for fertility treatment. So when they get to us to be eligible for treatment, the BMI needs to be 32 or less for the woman and the man 40. And the reason you'll notice is a difference of BMI of 35 for referral and 32 for treatment is just to get those people into the clinic to be able to see a specialist and discuss the importance of the weight loss and how they're pretty close to getting on the wait list for IVF, and just make a plan for them and how they're going to achieve it. The woman has to be less than 40 years old and the man less than 55. The CPAC takes into consideration how many children are living in the home already. It will look at the cause of infertility, as Lizzie's already discussed all the different causes and the severity of the infertility. It'll look at how long the couple have been trying to have a baby, and also take into consideration if the man's had a vasectomy in the past or if the woman's had tubal ligation. To be eligible for public treatment, they need to have 65 points or more on the CPAC, and once they get the 65 points, then they're eligible for up to 2 packages of public fertility treatment.
So I'm just going to move on to some case studies now. So the first one's just to illustrate some things about male factor infertility. So this couple were seen in the public clinic, a 27-year-old female and a 32-year-old male, and they had a 2-year history of primary infertility. The female partner had no previous gynecological history, regular ovulatory menstrual cycles, and she was generally fit and well with a normal BMI. The male partner had a history of previous testicular surgery overseas, so we didn't have any further information, but what he described was one day waking up with a swollen testicle, having some maybe fluid drained, and then his testicle shrinking gradually over time from that point, so that he now had normal left testis, and on the right side just a tiny little sort of remnant of a testis there. He had on his semen analysis a normal volume, a very low count of 0.35 million per mil, and none of his sperm were motile. So this was his first semen analysis in the community. So we repeated that at the clinic. He had, again, a normal volume, very similar count, and again, totally immotile sperm, which suggests that they're non-viable. So we couldn't freeze sperm. Normally in that situation, we would have been able to put the couple on the waiting list for fertility treatment, freeze some sperm so we can use it when they get to the top of the waiting list. But for him, first of all, we needed to investigate whether there was another contributing cause apart from his previous surgery. So we checked his hormone levels. This was to determine whether this was a primary testicular issue or a secondary issue, if he had any hypothalamic disorder. Check and see if he was carrying a Y chromosome microdeletion, which is a known genetic cause of male factor infertility. One of the other causes would be congenital absence of the vas deferens. On examination, this wasn't apparent, but we usually do check for cystic fibrosis gene mutation just because of, the implications of that if someone is a carrier. And we did get a scrotal ultrasound, which really confirmed the findings of the examination. But we're also looking for things like, does someone have a varicocele, or are there any sort of abnormalities that are not detectable on physical examination? So all of those things for him were normal, apart from the fact that he had this tiny testis on the right. So we recommended to him that we should take a surgical sample of his sperm. So we moved to a testicular sperm extraction, also known as a TZ. So this is done under local anesthesia with some sedation in the clinic, usually by a fertility doctor or sometimes by a urologist. We take a very small sample of the testes, which is then examined by the embryologist to confirm sperm is present, and then the sperm is frozen to be used for future treatment, which would be IVF with ICSI sperm microinjection. So the sperm from the testes also was immotile, but the lab did some clever tests to make sure that it was actually viable, and did freeze the sperm. The alternative in the situation would have been to seek a sperm donor if we couldn't find any viable sperm. So then the couple underwent IVF with ICSI. So the female partner had stimulation, and eggs were obtained, and ICSI was used to inject one sperm into each egg, as pictured in the image on the left of the screen there. The woman actually developed or was at risk of developing ovarian hyperstimulation syndrome. So we elected to only freeze embryos that were created so that she wouldn't go on to become unwell with that. We have nowadays some very robust methods of avoiding ovarian hyperstimulation syndrome. She then went on to have a frozen embryo transfer and very happily had a pregnancy with a live birth. The alternative, as I mentioned, would have been donor sperm treatment. So we are troubled by the fact that we don't have a lot of altruistic donors. We're going to tell you a bit more about third-party reproduction in a bit. But this does mean that there's a long waiting list for clinic sperm donors. 12 to 18 months is typical, maybe longer. Individuals are encouraged to seek their own sperm donor for this reason. If they do find their own donor, then we can work them up in the clinic and do all their necessary testing. But then there'll be at least a 3 to 6 month quarantine period for treatment. And there's just a bit of data there about all the donor insemination cycles across Australia and New Zealand per year. So there's quite a few cycles done, greater than 3,000 in the last ANZAD, that's the Australian and New Zealand Assisted Reproduction Database data from 2021. As you can see there, the live birth rates are higher in the younger population, so 17.3% under 35 years, 4.8% at over 40 years, and a 3.3% multiple pregnancy rate, so pretty low and quite acceptable.
Okay, 29-year-old woman with irregular periods, mild acne and hirsutism. She's been trying to conceive for 2 years. 5 years ago, she was pregnant and had a surgical abortion. 2 years ago, she was pregnant and had a partial molar pregnancy at the time of the miscarriage. And then she was pregnant 4 months ago and miscarried at 6 weeks. So, and her HCG peaked at 500. So that's 3 pregnancies over 5 years. When she was seen in the clinic, she hadn't had any bleeding since the miscarriage three months ago. So BMI was 26, noted the mild acne and hirsutism. Her hormone levels were normal. Normal testosterone level, an AMH level of 32, which I think is pretty normal for 29. All other tests were normal, and no recent ultrasound scan. So I've got a question, I think on the next slide. What would you do next? So we arranged made a booking for an ultrasound, which will take about 6 weeks. And we were planning to start letrozole after inducing a period with Provera for 5 days. So that was the plan. And just before I started to, we did a pregnancy test, which was positive that day. So remembering that the last time she bled was the miscarriage 3 months earlier. And her HCG was 640, which was was 4 weeks and 5 days. And then, and 6 days later was 6,123. So I put this case in really to highlight that not all women with polycystic ovaries are infertile or have I mean, she did have infrequent ovulation, but she still was actually pretty much fertile. Polycystic ovaries, it's badly named. They're not cysts of the ovaries, and I'd like to start an international campaign to call them multifollicular ovaries, but I don't think it would be successful. So they're follicles that have really, that lovely term, arrested in their development, and are lined up and are ready just to receive the signals from the pituitary gland, or perhaps from the drugs that we give them. It's the most common condition that we see, or the cause of an ovulation. And there's some other conditions around prolactin levels and hypergonadism, but really this is the most prevalent thing we see. So we have really very safe and effective ovulation induction available to us. And this is important, I think, because you can avoid perhaps the premature use of IVF, which with people with polycystic ovaries can be a little bit more challenging. So we aim to induce a regular unifollicular ovulation and minimize the risks of OHSS and multiple pregnancies. There is a big international guideline published, a second publication of it last year. Letrozole is first-line treatment now, but it's not publicly funded, and I will sort of explain a little bit about that. You can use metformin if you wish to, but it is not the most effective treatment, and women should be informed that there are more effective treatments, that is letrozole. And then clomiphene. Now, the data suggests that you can combine clomiphene and metformin, but once again, letrozole is still the first-line treatment. This is a network meta-analysis. I don't know if many of you know about these. It's a new thing, and you've got a network there where you can see all the different comparisons between clomiphene citrate and letrozole, FSH, etc., metformin, tamoxifen, and I can't think what PB is, but letrozole from this network has been shown to be superior to clomiphene for live birth, ovulation, pregnancy, and multiple pregnancy, and no difference in the miscarriage rate. And it's associated with less hot flushes, but more fatigue and dizziness than clomiphene. This comes from a big study, and you can see there's just, fewer hot flushes with letrozole, but more fatigue and dizziness there. Turning to another patient, this 40-year-old woman came back to see us. She had secondary infertility. She had been trying for a year. She had arthritis and was on some medications that her specialist had given approval that she could remain on them while she was trying to get pregnant. She was 14, she had an AMH of 20, which is kind of good for that age group. And she'd had a baby only 18 months ago. I think the baby was 18 months ago, and she'd conceived with IUI and clomiphene on her 4th cycle of IUI after 5 years of unexplained infertility. So, and we say that it's unexplained if there's been a normal ultrasound, hysterosalpingogram, ovulation, and normal semen analysis. So her first cycle of clomiphene with the IUI, she had an overresponse to 50 micrograms, which is the standard dose. And so it was reduced to 25. And as I say there, she conceived on the, she had 5 cycles, but she conceived on the first one was cancelled. So then she had 4 cycles after that and conceived on that 4th cycle, and the baby was born at term. Anyway, she came back. She's not eligible for more treatment at this point. And she, by the way, she used one of her packages. For IVF, you get 2 packages of, sorry, for public funding, you get 2 packages. One could be two cycles of IUI, 2 cycles of IVF, or you could have 4 cycles of IUI and 1 cycle of IVF, or you could have 8 cycles of IUI. She was concerned about how she would respond to IVF, and so she chose IUI. And this time she's used her public funding, so she decided to pay for 1 cycle of IUI at 40. And so here's her cycle details. We used letrozole. She was scanned on day 11. She had 2 follicles. She had a trigger, which means that we exactly know when she's going to release the egg, and we can time the insemination. And she got pregnant with twins at 40 with IUI, and they delivered naturally at term. So I put this case in really just to say that 40-year-old women can have IUI. A lot of people think it's a treatment that we should, use for younger women, but when you get to 40, you're just going to have IVF as the most successful treatment, because it is, obviously successful. So here is the ESHRE guidelines. It's the European Society of Human Reproduction and Embryology guidelines in 2022. First-line treatment for couples with unexplained infertility is intrauterine insemination. And here is our own study from New Zealand of time to pregnancy. It was actually called the TUI study, which stood for the intrauterine insemination study. And you can see, again, another graph, as you've seen before, with the cumulative live birth rate. And these are all patients who had, I think their mean length of infertility was something like 40 months. And the blue line there is expected management, and the green line there is intrauterine insemination. And that was with 3 cycles, so it was a cumulative pregnancy rate. So we are, and that was one of the studies that was used in the ESHRE guidelines. It was clomiphene citrate, although with the previous patient, we did change her to letrozole because she'd over-responded previously with clomiphene. But generally clomiphene, it's safe and effective for women with unexplained infertility and an unfavorable prognosis for natural conception. And that was the unfavorable prognosis being the length of infertility in that case. So is it IUI or IVF for unexplained infertility? And we've been recruiting a large study for something called the FIX study, which around fertility, IVF, IUI, and unexplained. So that's where we get the X from. We call it the FIX study. And we've just finished recruiting over 700 couples for this. And the question is whether women should have IUI prior to IVF. Are 4 cycles of IUI the same as 1 cycle of IVF? And are 4 cycles of IUI followed by 2 cycles of IVF better than the 2 cycles of IVF? So we're, some of those questions will be answered, or hopefully all of them will be answered by that study, although it's already been kind of decided, the recommendation is that would be IUI would be first-line treatment.
So I'm just going to run through some third-party reproduction and do a case study on that. So in New Zealand, we have got sperm donors, egg donors, embryo donors, and surrogates. Donors can be clinic recruited, or they can be known to the patient, as been discussed already. If they're clinic recruited donors, if they're egg donors, we prefer them to be 25 to 35 years old. If they're a sperm donor, we prefer 20 to 45-year-olds. And if they're embryo donors, we prefer them to be less than 37 years old when their embryos were created. If the patient has recruited their own known donor, it might be a sister or cousin or brother, then we are happy to go outside their age range after the patients have had a good discussion with their consultant about the risks of that. All donors go through some vigorous screening, and that includes infectious diseases, genetic carrier screening, a thorough medical history, a family history, discussing lifestyle risks, and the frozen sperm and eggs go through a quarantine period before they're used for treatment. And the donors and recipients also have mandatory implications counselling, and that's individually and then joint. If it's a embryo donation case or surrogacy case, all the parties involved will have counselling together, and that's to discuss implications of the donation, the laws in New Zealand, and if it's a surrogate, what difficult questions that might come up through the pregnancy, so everybody's on the same page. So in New Zealand, the key law that regulates assisted reproductive technology and human reproductive research is the Heart Act 2004. There's just a table here to show that there is things in the Heart Act which are classified established procedures. That's our everyday IUI and IVF procedures. Then there's a list that requires ethics approval, for example, surrogacy, and then there's a list of prohibited actions that we cannot do in New Zealand. So surrogacy is available in New Zealand, and it is an altruistic event. It is not commercial surrogacy like overseas. Actually, I should say all donation in New Zealand is altruistic. So that's when another woman agrees to become pregnant for another couple who are providing usually their own genetic embryos, maybe because they don't have a uterus. As I said, commercial surrogacy is not allowed. Surrogacy is really ethically complex and legally very complex sort of thing to undertake, as it involves risks for both adult parties and the resulting children. Every surrogacy case in New Zealand has to go to the ethics committee, which is called ECART, and the ethics committee have to be satisfied there's a real need, a medical need for surrogacy, and that the proposal is justified in light of the associated risks for all the parties involved. In Australia and New Zealand, we do about 350 surrogacy cycles per year. So moving on to this case study, we had a 35-year-old lady and a 30-year-old man come to see us, and they've been wanting a baby for 5 years. The lady had MRKH type 2 syndrome, which is when she just had a rudimentary uterus. So it's a non-functioning uterus. She had an absent left kidney. So because she didn't have a functioning uterus, she needed a surrogate. Both her ovaries were present and functioning, follicles were seen, and she had an AMH of 15.4. We checked the sperm, and he had sperm, variable counts and motility. So the treatment plan was to do a surrogacy cycle, stimulate this lady with our sort of standard protocol, which is called an antagonist cycle, with the maximum dose of FSH drugs. She needed to have a trans-abdominal egg collection under GA, which is not our usual route of doing an egg collection, but because with MRKH syndrome, the ovaries sit quite high in the pelvis, they're quite hard to access vaginally. We were planning to do ICSI because of the sometimes low sperm counts, and then we would freeze all the embryos so that they could be later transferred to a surrogate. So the first step really is to do the ECART application, which is a very involved process and can take quite a few months. So what's involved is a medical report for the intending parents, and then also a medical report for the birth parents. So that's the surrogate that's going to give birth to the baby. There'll be implications counselling for intending parents and for the birth mother and her partner, if she's got a partner, and then another counselling session or multiple counselling sessions with all the parties involved. And both the intending parents and the birth parents need to get independent legal advice, and they also need to have a adoption pre-assessment from Oranga Tamariki, because the birth mother is the legal mother in New Zealand, and the intending parents need to adopt the baby. So this lady started off her first IVF cycle, and she got, I think, a good number of follicles developing, and went in for the egg collection. And unfortunately, she had ovulated prior to egg collection prematurely. So all of her eggs were already gone on the first cycle. So back to square one, start again. So we started stimulation again. We changed the protocol now to a long downregulation cycle. This time we got 5 eggs, and 2 of her eggs fertilized, and she had 1 embryo suitable for transfer. We transferred to her surrogate, and unfortunately the surrogate had a miscarriage. So the intending parent came back for her 3rd cycle of stimulation. We repeated the same stimulation. This time she got 7 eggs, 4 fertilized, and 3 embryos were suitable for transfer. So the surrogate had 3 more embryo transfers and unfortunately didn't get pregnant from any of those transfers. No embryos were remaining at this point, and now her public funding was complete because she'd had her 2 full packages of public IVF. So the next step was for her to consider an egg donor along with the surrogacy. Unfortunately, she was not able to find an egg donor, so she moved on from egg donation to considering embryo donation. And donor embryos come from other people that have had IVF in the past and have finished their families and have got spare frozen embryos left over, and they altruistically want to donate them to another couple. So fortunately for our lovely couple, they were matched with some embryo donors and they were all happy with the match. This required a repeat ECART application because now there was new parties involved, and that meant repeat counselling and repeat ECART report, and that got approved. And so the surrogate came back and she had transfer number 5, first one with the donor embryos, and unfortunately a miscarriage. Transfer number 6, another miscarriage. Transfer number 7, finally a lovely baby girl. So now moving on to pre-implantation genetic testing. So there's 3 different types and reasons for doing genetic testing of embryos. PGT-A is screening of whole chromosomes, and this is not funded. All patients need to privately pay for this themselves. PGT-SR is screening for translocations, and this can be funded. And then PGT-M is testing for monogenic diseases, and this can be funded as well. To be eligible for PGT-M, the couple has to reach the same criteria as IVF, so that's the age and BMI and work visas and residency. And then to be eligible for the testing for the genetic disease, there has to be a 25% or greater risk of an affected pregnancy, and there must be evidence that the future child would be seriously impaired as a result of that disease. They would not be eligible if they already have 2 or more unaffected children. So I've got a case study here for a PGT case, 30-year-old man and woman. The woman's father, grandfather, auntie and brother all affected by Huntington's disease. So the female went and had testing, and she herself was also found to carry the Huntington's gene HTT. And this is an autosomal dominant condition. So they got eligible for PGT-M, and the first step with us is to do feasibility studies. And this is when the genetics lab have to create the probe to do the test and check that they're finding the correct mutation. So the lab have to get certain family members' DNA, and in this case they needed the woman's partner's DNA, and so her DNA, the husband's DNA, and her father's DNA. And the workup of the PGT-M case can take approximately 6 weeks, but it can take much longer if it's a de novo mutation. And the results of the PGT-M testing are about 95 to 98% accurate. So they're all recommended to have a CVS or amnio once they're pregnant to double check. So this lady, as I said, was eligible for her public PGT-M and IVF. So in her first cycle, she got 9 eggs collected and 4 fertilized with ICSI, and she had 4 embryos biopsy. The results of the testing were that 2 embryos were affected with the Huntington's gene and 2 embryos were not affected, but one of the embryos was a mosaic monosomy 21 and the other one was a monosomy 19, so no suitable embryos to transfer. The second cycle, because there was no embryo suitable to transfer, she was eligible for a second cycle, and this time she got 8 eggs, 4 fertilized, and again 4 embryos suitable to biopsy in the lab. And from her 4 embryos this time, she had 1 embryo that was not affected by Huntington's. It was euploid, so had a normal number of chromosomes. She had 1 affected with Huntington's. She had 1 embryo with no result. So we rebiopsied that embryo, and again, no result. And then we rebiopsied the embryo for a third time and found it, in fact, was affected by Huntington's. And the fourth embryo was an inconclusive result, which means that there was insufficient DNA or poor quality data. So she had an embryo transfer of her one unaffected euploid embryo and had a lovely baby boy.
Excellent. Thank you so much, guys. That was a lot to fit into 1 hour. So there's a number of questions around the quarantine period for donor sperm and eggs. Can you guys shed some light on that in terms of what that is and why that's important, please?
So say when a sperm donor comes through, what we do is we do infectious disease screening first. So we check HIV, Hep B and Hep C, HTLV and some other various tests. Then we freeze the sperm, we quarantine, which means just keep it in the freezer for 6 months, and then we retest all those virologies again and check that we've got 2 negative tests 6 months apart, and then we call it cleared sperm and it's out of quarantine, and then we can release it to be used in women's treatment so that we know it's very, very low risk for for disease.
Well, thank you, Jeanette. And does that apply to donor eggs as well?
Yeah, so egg donors are slightly different because we can freeze eggs, but we don't routinely freeze eggs. So we do 2 sets of blood tests on the woman prior to egg collection. So it's not so much frozen eggs being quarantined. We do serial bloods on the woman.
And Jeanette, you talked about the seminal fluid analysis earlier in terms of the fructose test. Can you just explain that a little bit, why that's important?
So when you have azoospermia, it could be an obstructive cause, a blockage. So that would be like, for example, bilateral absence of the vas deferens, or it could be non-obstructive. So the fructose measurement does help us to determine which of those causes it might be. So it's not, we wouldn't use it on its own. We would use it in conjunction with, doing an examination, checking their FSH and LH, etc. But it's just another clue.
If a woman is looking to donate an egg after her own pregnancy, is there kind of a quarantine or stand down period from that?
Well, we'd
prefer them to
be not to be breastfeeding. They need to have some time to have recovered. So we probably wouldn't want to do. I can't think of someone who's turned up within. I mean, I think we've had some donors after a year after a pregnancy, but not less than that. And breastfeeding actually does have quite a big impact on your reproductive cycles, as you know, but on the endometrium in particular, and it wouldn't be sensible to do it then. And then we also like to just know that the egg donors are are well counselled, and they the year after you've had a baby may not be the time that you're making the best decisions. I don't know. So we would like people to take their time to make that decision. I mean, of course, donating gametes is not just oh look, I've got eggs, you've got sperm, let's freeze it. It does have lifelong consequences, the donation of gametes, and so we do like people to have time to think about it. And I think Jeanette's mentioned about the Heart Act and the requirement for disclosure to offspring, and in fact we're just about to set a survey in process, finding out about how many parents have disclosed to their children since the Heart Act came in. So it's on our minds, and we take it fairly slowly when people want to donate eggs and sperm, not a rushed decision.
For regional New Zealand, where they may not have any kind of fertility services available, what are the options for treatments there?
Yes, so Fertility Plus has got no other clinics. We're just here in Te Toko Tumai. We cover the region, and we do cover the Northland region as well. So the way it works is that the 3 clinics have the patients are allocated to each of the clinics randomly, although we get 60% of the referrals and the other 2 clinics get 20%. We don't have a outpatient clinic in the north, but both of the other two clinics do have an outpatient clinic in the north. So I guess I'm rambling here. So in terms of, and then Fertility Associates runs the rest, you know, all of the clinics are in the rest of the country, and they do have a lot of clinics in smaller towns and as feeder clinics, I guess. So what was the question really? It's just what can you do regionally? It is a challenge. People do have to travel, and it is really hard trying to do an IVF clinic of IVF cycle when you live in Kaitaia, and you know, you have to commit time to come down and be local. So we do appreciate that, but they're expensive laboratories that we can't just transport around the place, unfortunately. Do you want to add to that, Lizzie or Jeanette? Because
well, I guess just to say that the IVF clinics around New Zealand with labs are situated, obviously 3 in Auckland. There's 1 in Hamilton, 1 in Wellington, 1 in Christchurch, and 1 in Dunedin. But as Cindy mentioned, there's satellite clinics to those main cities that Fertility Associates will consult in the smaller towns, and they'll be able to provide consultations and maybe some of the investigations there. Oh, and also I think there's a IVF clinic in Mount Maunganui now as well, opening soon.
Is there any role for testing progesterone or prescribing progesterone in women that are troubled by miscarriages or recurrent miscarriage?
So there's been quite a lot of research in the UK on this. And the sort of short answer is probably yes, but the specific studies that were done really only proved that progesterone, the answer to testing progesterone levels is no, that wasn't done, and I wouldn't recommend doing that routinely. But in terms of supplementing progesterone, if somebody has a history of recurrent pregnancy loss, and in their current pregnancy, they have some bleeding in the first trimester, so a threatened miscarriage, the research that's been done says that yes, definitely they would benefit in terms of improving their chance of a live birth from using progesterone supplementation. And so the routine dose for that was used in the studies was 400 milligrams twice daily of Utrogestin, which now, of course, is funded. So extrapolating from the studies that was done in the UK now, they do recommend using Utrogestin even if someone doesn't have a threatened miscarriage in the current pregnancy. So particularly if they've had higher order previous recurrent miscarriage, so that's kind of 4 miscarriages or more, they would definitely suggest using it then. But I think most of your women coming to you after having 3 miscarriages are going to be asking for it, and there's probably no harm. There's now no cost, so we would support you providing that to them in primary care, I think. Do you agree, Cindy?
Oh, I'm slightly, I think if they're bleeding for sure. I've just actually been reviewing this for a college statement. UK, somebody has written an article about the UK. Did NICE get it wrong about the recommendation for progesterone? About it, I think the data really sits with people having 3 or more miscarriages, possibly 2. But I mean, you guys on the call, you might be getting patients, you know, even on their first, second pregnancies, very anxious and wanting progesterone. So it's still a bit of a grey area, I think, and it's not that, and the treatments are not. It's not. No treatment is completely safe, if you know what I mean. In the beginning of pregnancy, when the organs are just forming, I think there's a little bit of concern, I think, with some progesterones, not Utrogestin, but the other progesterone has been associated with some cleft palate defects, I believe, Digogestin. So I don't know. I'm not quite as confident. What do you think, Lizzie, about what I'm saying?
I think there's that slippery slope thing, isn't there? And you know, you start off with giving it to those women with who've had many miscarriages before, and you end up giving it to people who've only had one, and how did we get there? And I don't think there is evidence to support that degree of use. Yeah.
And we'll just finish with, I guess, a question / a comment someone's put here, which I was also going to ask. I don't know if this person also works in South Auckland, but the BMI cutoff for referral being under 35 and being accepted under 32, it's pretty hard because a lot of our women are Māori Pacific, and they just are nowhere near that. And even if they're kind of on a weight loss journey or trying their best, it's, I guess, from an equity point of view, it's quite tricky. So I don't know if you guys have any thoughts on that.
We agree.
Yeah, I mean, the public, like, the criteria are there for a reason, several reasons. The way I see it is that we are fortunate to have some public funding for fertility treatment in New Zealand, but it's very limited. So how else are you going to make sure that is best used other than giving it to those people who are the most likely to benefit? So that's how all the CPAC criteria was come to, in terms of, you know, age, BMI, duration of time trying, etc. So that it was supposed to give those people most likely to need fertility treatment, the treatment first, so those with blocked tubes or no sperm, but also those who are most likely for it to work. And we do know that having a higher BMI, if you're going through IVF, you're going to get fewer eggs, because the drugs just don't have as good an effect when you're overweight. And also, we have to remember that there are higher risks in pregnancy with a higher BMI. So we are, you know, trying to look after women as well. It does seem harsh, and it probably needs to change. I'm speaking out of turn here, really, because I'm not involved in this, but it probably does need to be ethnicity specific. That's where it's probably a bit unfair.
Alrighty, well, I think that's all of our time. Thank you guys so much for your wisdom and your time tonight. Cool. Thank you. Good evening, everyone.
Thank you.